going to continue with the lectures, and this afternoon we are going to focus on atopic dermatitis in dogs first, then the equivalent disease in cats, which is feline atopic cutaneous syndrome, and then at the end we will review a few clinical cases and how to manage them of different diseases, not atopic or in cats and dogs and cats. Let's see if it's working. Yeah. Atopic dermatitis is probably the most common and most important disease that we see in dogs. Skin disease, I'm meaning. It's a very common condition. The recent epidemiological data report that probably 15% of dogs overall are affected by this condition. In some breeds, for instance, West Highland White Terriers, French Bulldogs, there can be over 40% of dogs. So it's a very common condition. Just to give you an idea, in a, let's say, normal day at my hospital, if we see, let's say, 15 or 20 dermatologic patients, 50% are atopic dogs. And someone just this morning mentioned the saying that is a very common condition. It's surprising that being so common, well-known disease, so many patients end at a referral hospital, because you expect that we see only uncommon, rare conditions, difficult cases, but many of the cases are simply atopic dogs because the management of the condition, it's difficult and is not adequately, let's say, approached in many cases. So it's relatively easy to see that this dog, this patient, Benjamin, a 2-year-old young dog with a very pruritic dermatitis, is an atopic dog after ruling out other conditions. It's more difficult to know exactly what is the best treatment for this dog, because now we have plenty of treatments and it's not so easy to define how to manage the patient on the long term. And in many occasions, what makes difficult the management of these cases is that the owners are not prepared to understand that this is a lifelong condition. In many of my patients, when I make the history of this dog and ask, well, I've been treated with Apoquel, and they say, yeah, when I stop Apoquel, still the same. I say, yes, but this is normal. This dog needs treatment lifelong. I don't think that if you have a diabetic dog and you go to the internist, say, you give the insulin, say, yes, but when I stop insulin, it's back again. So it's not cured. No, of course it's not cured. We need a lifelong treatment for these dogs. So we cannot cure atopic dermatitis, as you know. We can manage this well, but we cannot cure that. And the owners, in many cases, they have the expectation that we are going to cure this condition. So let me quickly review what we know about atopic dermatitis, because this is a disease that has changed a lot recently. Classically, atopic dermatitis in dogs is defined as an inflammatory and pruritic skin condition associated with the production of IgEs against environmental allergens. And we know that these allergens penetrate through the skin, that usually are mites, house dust mites, food storage mites, pollens, molds, and that this penetration triggers an hypersensitivity reaction mediated basically by IgEs, and that initially is a T helper 2 immune response, but also with T helper 1 components. But this is the classic definition. Now, because many different investigations have brought more information, we know that basically there are 3 abnormalities in dogs with atopic dermatitis. One is this immune dysregulation that makes that when these dogs contact with these allergens, they develop an abnormal immune response. abnormal in the adaptive and in the innate immune response, leading to the production of many cytokines, inflammation, itch, IgEs, what we know. This is a big part of the condition. But we know that also the abnormalities in the skin barrier, it's part of the mechanism. And this is especially important in children. We know that 40% of children with atopic dermatitis, they have a genetic deficiency in one protein of the epidermal barrier called filaggrin. And we know that in dogs, this epidermal barrier is also abnormal, allowing more penetration of allergens. So it's not only that these dogs are predisposed to develop an abnormal immune response, it's also that the barrier is not normal in these dogs. And finally, we know that in the skin surface, there is an abnormality in the skin microbiota. We have a very well-defined composition of the bacteria in our skin. Many. In dogs, we have identified at least 1,000 different bacteria living on the skin of the dog. And in these atopic dogs, the composition and the diversity of these skin microbiota, it's different. There's less diversity, there is predominance of some bacteria that are not so protective. These three things together makes that the dogs develop this chronic inflammation of the skin that lasts lifelong. And this makes that when we try to treat this patient, we have usually to target different parts of the condition. We need to control the itch, we have to reduce the immune response, the hypersensitivity and the inflammation. We have to repair the skin barrier, and if possible, we have to increase the diversity of the microbiome. So these different targets are not always used in the treatment of a patient, but sometimes we need to take in account that we need to do all these things to have a healthy skin again, to repair completely the skin of one atopic dog. And you will see that in the treatment of atopic dermatitis, there is not a single treatment. When I was younger, people used to ask questions like, what is the best treatment for atopic dermatitis? What do you use for treating this dog? Depends. Depends on each case and how is the skin, how is the microbiome. So you need to make a different treatment for each one of these patients. And in many cases, you need the cooperation of the guardians, of the pet owners, because I usually tell them, I know the overall data about oclacitinib, about cytopoint, about cyclosporine, about any treatment, but I don't know exactly what will be the best for your dog. We need to try, see how respond your dog. You need to help me, and then we will find what is the best treatment for her specifically, and then we will maintain that. So the condition, it's very typical from a clinical point of view, and I'm sure that you all recognize atopic dermatitis. It's a disease of young animals, usually begins between 6 months and 3 years. Now there are a couple of studies, very interesting, showing that many dogs develop atopic dermatitis before 1 year of age. A recent study done in Switzerland follow 100 West Highland White Terriers, and they detected that almost 40% of them had signs of atopic dermatitis before 1 year of age. So it's very common to develop the condition early in life. We also know that there is a clear breed predisposition. Boxers, Sharpei, Dalmatians, English Bulldog, all terriers or many terriers like Boston, Cairn, Scottish are clearly predisposed. West Highland White Terrier. Sex doesn't play a role in the disease. Males, females, spay, non-spay have the same proportion of disease. And seasonality is variable. Probably 25% of the cases are seasonal, and the vast majority are non-seasonal. So they have lifelong, around lesions. What is important is that the main clinical sign is pruritus. They, in many cases, develop the condition with only itching and very mild skin lesions. Another very typical characteristic of this disease is the location of the pruritus. Atopic dermatitis is typically a disease of the face and ventral parts of the body. So when you look at a patient with atopic dermatitis, I will show you examples now, you typically see the inflammation and the lesions on the ventral parts of the body, on the axilla, on the ventrum, on the groins, and the distal legs. And initially, the lesions are basically erythema or a few papules, and quickly they develop secondary lesions like salivary staining, excoriations, self-induced alopecia, more epidermal collarettes, crust, and many dogs end with lichenification, a thickening of the skin that is very characteristic. Remember that together with the skin problem, dermatitis, you have otitis externa in many dogs, with conjunctivitis in about 40% of the dogs. They have this follicular conjunctivitis, if you look, and many dogs develop secondary infections, bacterial or malassezia overgrowth. So this is how the disease looks. So very typically, this is the distribution of the lesions in atopic dermatitis, and you have to see that they typically around the eyes, muscle, flexural areas of the legs, and distal legs. So the dorsal part of the body is usually spare unless there is folliculitis, bacterial folliculitis. Another interesting feature of the condition is that the lesions of cutaneous adverse food reaction, also called food allergy, and atopic dermatitis are identical. So clinically, they look exactly the same, this distribution of lesions. So this is the classic atopic dog. They are a young animal that present erythema on the face. You see better here around the muscle, around the eyes. The dog is scratching. Then on the axilla, the ventral neck. Here the axilla again. Groins, abdomen, erythema, papules. Very typical lesions of an atopic dog. This is a more chronic patient, so the lesions are more established. So the alopecia around the eyes is very prominent, around the muscle, neck. And when you look, the groin area is clearly affected. And we start to see here, although this is an acute flare of the disease, we see here that in some areas we start to see lichenification, meaning that we see the surface of the skin thicker and the marks of the skin surface more prominent. And then when the disease becomes chronic and we are not seeing a flare of atopic dermatitis, but a chronic permanent case, then the lesions are on the same locations, but they look more lichenified and hyperpigmented. Look at this West Highland White Terrier, and you see that the lesions on the paws are more hyperpigmented. The dog is licking this area, has caused what we call excoriations, so erosions induced by licking. And this is the perivulvar area. This is what we call a lichenified area. So the skin is thickened, and the surface of the skin, the markers are more prominent, and is also hyperpigmented. Remember that pigmentation of the skin with melanin is a normal mechanism of defense of the skin. So only shows that the skin has been damaged by the inflammation, and it's a reversible lesion. So if you treat this skin, the black pigmentation, this dark, will disappear. It's simply melanin in the dermis. In many cases, you will have dogs like this one, that the owners came to me and say, we are desperate, the dog is really, really bad. And you look at the dog and say, it looks fantastic. That's because the lesions in atopic dermatitis are typically on the ventral parts of the body. If you look at this dog, you see where the lesions are. This is a classic atopic dog. So the lesions are located in these areas. And you see that they are quite chronic. So you see these black areas, there are some red areas, very active inflammation, and then there are also black hyperpigmented areas, lichenified areas. And this is the same in a very chronic case. So the lesions become more and more chronic with time, but they remain on the same areas. So if there is no infection, the affected areas are here, the axillary regions. And this is the classic lichenification that we see. This is a lesion that is very special. Lichenification, it's only seen in dogs and humans. Cats usually do not present lichenification. Horses a little bit, but dogs, when they have a chronic inflammation of the skin, tend to lichenify the skin. And you see the same on the paws. This dog is probably licking these areas that are inflamed and very itchy. Atopic dermatitis targets about 15% of dogs. But not in all cases, it looks exactly the same. It doesn't look the same in distribution of the lesions, and it doesn't look the same in severity. In some cases, you can simply manage the condition with a very mild treatment. In other cases, you need to be very aggressive and use combination of different drugs to stop the inflammation of the skin. And it doesn't look the same about the distribution of the lesions. I don't have time to go into details, but this has been very well established. It's what we call the different phenotypes of the disease. And in atopic dermatitis, the phenotypes are clearly connected to the breeds, to the different breeds of dogs. For instance, and this has been published and well, let's say, investigated. For instance, we know that in German Shepherd dogs, typically the inguinal region is the most affected. We know that in Shar-Peis, the distribution of the lesions can be even dorsal, so it's all the body that is affected. We know that, for instance, the French Bulldog tend to have more facial lesion. Each breed has a different pattern, and there are books talking about this, and it's convenient to identify the different presentation of atopic dermatitis in the different breeds, because one is the big picture, facial, ventral areas, and then each one has different peculiarities. Golden retrievers and Labradors tend to have more otitis as the single manifestation of atopic dermatitis, for instance. So this is the clinical, let's say, picture of atopic dermatitis in general. How is the diagnosis of atopic dermatitis? Well, it's important to remember that we do not have a diagnostic test for atopic dermatitis. There's not a test that allows you to say this dog is atopic or not. What we call allergy tests, in fact, are not tests for diagnosing allergy or atopic dermatitis. They are tests to select allergens for immunotherapy. The diagnosis of atopic dermatitis in all species, in cats, in dogs, in humans, in horses, it's a diagnosis of exclusion. So we need to rule out other conditions, and then clinically we diagnose atopic dermatitis. And only when we have done this, and we know that this is a case of atopic dermatitis, we begin with the treatment, and we can do allergy tests to identify the allergens. If you use the serum-based test or the intradermal skin test to diagnose atopic dermatitis, you will get many false positives, because if I test 100 healthy dogs, about 40 or 50% of them are positive for allergens. So I can conclude that these dogs are atopics, and they are not. If I do the test, people sitting in this room, many of us will have circulating IgEs, and we are not having clinical signs. So the tests are not useful for establishing a diagnosis. Many other conditions can make even more positive a dog. Sarcoptic mange, for instance. Most dogs with scabies are positive to the allergy test. If you do this, you can have wrong result. So the diagnosis is based on a very systematic diagnostic work. If you have a dog that has a clinical picture that is compatible with atopic dermatitis because of the age, the breed, the type of lesions, the presence of severe itch, then you have to rule out conditions that can be responsible of this presentation. We can begin with other parasitic or infectious diseases, rule out scabies, flea allergy dermatitis, pyoderma malassezia with different tests, skin scrapings, or serology for scabies, looking for fleas. If you have any doubt, be sure that the dog is an adequate treatment for ectoparasites. Now we have isoxazolines, it's very easy. Then doing good cytology, rule out bacterial overgrowth or bacterial infection, and the same for malassezia. And when we have ruled out these conditions, then we do the food trial to rule out a food adverse reaction. This can be usually done in 2 or 3 different steps. In the first consultation, you rule out fleas, scabies, Demodex, so these easy things. And if you have ruled out all these conditions, then, and you have investigated secondary infection, then you do a food trial to rule out food allergy, because these 2 conditions are very similar. And if we'll see now, if the test is, or the food trial, it's not effective controlling the condition, then we consider that the dog has atopic dermatitis. So the food trial can be done with homemade food or with commercial food, prepared food like this that you have here. And usually it's a test that lasts for 8 to 10 weeks. What I tell to my clients is that I know it's complicated. It will be 8 to 10 weeks, but it's important that we know the role of the food in this process, because this dog will be lifelong affected by this condition, and it's important to know if with food we can manage this condition or not. There are cases when we have both conditions together, food allergy and atopic dermatitis mixed together. And I need to know how far I can go just managing the food component of that to control the disease. If after doing this food trial, I see a dog that is 80% better, I know that food is very important. That food will be a big part of my management on the long term. If after 8, 10 weeks, the dog is exactly the same, I know that food is not important, the dog is allergic to other things, and simply I need to use drugs or immunotherapy to manage this condition. So I know it's complicated, but it's very helpful to define the long-term plan. You have to understand that allergic dogs, like allergic people, are not allergic specifically to one thing. We are not born allergic to chicken or to pine tree pollen. These dogs and these children, they have a genetic predisposition to have an abnormal immune response. If they are exposed to chicken, they become allergic to chicken. If they are exposed to pine tree pollen, they develop allergy to pollen. If they are living in Florida and they have palm trees, they will become allergic to palm trees. So it's important that we know if the amount, and they usually develop allergy to several things. So it's important that we use this information to know if part of the allergy is caused by food or not. Unfortunately, also in the market, many labs offer serum tests to detect allergy to, let's say, food proteins. We know that these tests do not work, those on saliva, those in serum. So it's a waste of time to use this to know if the dog is allergic to some food ingredients. I have every day clients coming to me saying, we have done a food allergy test and the dog is allergic to chicken, tuna fish, beef, eggs, cheese. I say, well, this is just not useful. Forget all this information. If we want to know if the dog has some type of food adverse reaction, we need to do a trial. So far, all the tests that have been developed have failed to have clinical relevance. We detect IgEs, IgGs on the serum of these dogs, but there is no correlation between the clinical signs and the results of the tests. It's true that in some cases, it's difficult to do a pure test. If the dog is absolutely itchy, they say, I don't know if it will be possible to be 8-10 weeks only with the food and without any treatment to see. That happens. In some cases, what I tell them is, we can do the test later. We can now manage the condition with drugs, put the dog in good condition, and then we know that someday we will need to investigate if the food is important to reduce the medicines. Or another thing that you can do is, well, and I do this in many cases, the first 3 or 4 weeks, I will give you some medication. Prednisone, Apoquel, an injection of Cytopoint, and after 3-4 weeks, we will stop that and we'll continue only with the diet. And then when you come back after 8 to 10 weeks, we will talk about that. If the dog was doing well at the beginning, but when we stopped the Apoquel, the itch came back again, we know that the diet is not helping. The same with Cytopoint that lasts for 4 weeks, more or less, or steroids. You can give tiny amounts of steroids 3-4 weeks, and then stop the steroids, and then continue with the diet. And after 8-10 weeks, you see the dog again. If it's improving with the diet, we will start to consider diet is important in this case of allergy. I usually expose the dog back to the previous diet for 2 weeks, and if the dog starts to itch again, I say, it's clear. The allergy is caused in a big part by food. And then I need to find a good diet, usually a monoprotein diet, for the long-term management. They can continue eating this diet, but in many cases it's better to change to another for the long-term management of these patients. So when you have ruled out parasites, infectious diseases, and food allergy, you consider that your dog has atopic dermatitis. This is a clinical diagnosis. It's not a diagnosis made by one test. And we are lucky because this condition has been investigated a lot, and we have very clear recommendation about how to treat these dogs. So it's not necessary now that each one make changes and trials, because big group of experts review the recommendation about the management of atopic dogs. And there are guidelines that are in open access. This is the last one, this is 2015, but now there are almost ready for the next edition. And they clearly give you the guidelines about how to best manage these patients. And they say one important thing is to separate two situations. One is the management of the acute flare of atopic dermatitis. This is step one. I have a dog that is itchy with inflammatory lesions. It's doing bad. The owners are upset and so. The majority of our cases, when they come to the hospital, they come because it's an acute flare of the disease. And for these patients that present this acute flare of the condition, they recommend basically increase hygiene, bathing frequently. So we know that this helps a lot normalizing the skin microbiome. You can use chlorhexidine or miconazole if there is Malassezia overgrowth, or you can simply use a moisturizing antipruritic shampoo. What is the frequency of bathing? I would say managing the acute flare, the beginning 2 or 3 times per week. So very intense bathing at the beginning. I tend to tell the owners, When this is controlled and the dog is doing well after usually 4 weeks, you will begin to bathe the dog once a week, and this will be the long-term management of this. But now we need a lot of intensity managing the case. If there are deep infections or in the cytology you detect clear signs of secondary infection, you can use topical treatment or even in some cases systemic antibiotic treatment. This is the type of dogs in an acute flare. So very inflamed, very itchy, with, in this case, there was some malassezia overgrowth. These are dogs also with a very acute flare of the condition. So you see that there is a lot of inflammation around the eyes, the ventral pinna, around the muscle. Also, at the beginning of the treatment of the acute flare, we need to stop the pruritus. And we are lucky because now we have different drugs to do that. But it's very important that these dogs stop itching immediately or very soon. And we have 3 options only to do that, to begin the treatment of these patients. Use topical or systemic steroids, use oclacitinib, or use the monoclonal antibody cytopoint. Other options like cyclosporin, immunotherapy are not adequate at this phase. So in some cases, I see vets that begin immunotherapy expecting to control this. This will never be controlled with immunotherapy. Immunotherapy is a long-term treatment, but we need now to stop the itching of these dogs. And we can do using any of these drugs. Steroids usually can be used at very low dose. In big dogs, even 0.5 milligrams per kilo a day for 1 week. And then you taper the dose, 0.5 milligrams every other day for 1 or 2 more weeks, and then even half of the dose, 0.25 milligrams every other day, the 3rd or 4th week, and then you discontinue that. You simply stop the flare at the bathing, control the secondary infection, check that it's on good parasite control, and then we have to decide what are we going to do in the long term. But for the flare, that is usually 4 weeks, this is enough. Apart from steroid, you can use Apoquel. It is a very effective drug. You know that the dose of this Janus kinase inhibitor is between 0.4 and 0.6 milligrams per kilo every day. It's mainly a Janus kinase 1 inhibitor. It's not registered as a selective Janus kinase 1 because it has some impact on Janus kinase 2 and 3, but mainly it's Janus kinase 1 and is pretty safe and act very quickly. You know that we give this BID twice a day for 2 weeks and then once a day at this dose. We know that there are some limitations to the use. We cannot use this in dogs less than 1 year of age or dogs with severe infections. You can use it in cases of superficial pyoderma or malassezia overgrowth. This is okay. Not if the dog has a very severe, deep, suppurative infection of the skin and cannot be used in other species. Oclacitinib has clear advantages in front of steroids. It's very quickly, acts very quickly, stopping the itch. It's very easy to use. We don't need a test. Has very few side effects. Has been reported a few changes in hepatic enzymes, in cholesterol, a little bit elevated in some dogs, but very, very few, a little bit of weight increase, no secondary infections, no urinary tract disease, so it's pretty safe. We can combine this with other treatment, topical or systemic, and we can do the intradermal skin test or the serum test while the dog is on Apoquel. So we can begin with Apoquel, control the acute flare, and when the dog is doing well, say, you want that we start to think on the mid and long term, we can do the allergy test and decide if we can control this adequately. Weaknesses, the problem is that usually if you begin with Apoquel, you need to use this every day, long term or lifelong. So some owners at the beginning are very happy, but after a few months say, I see that every time that I don't give the pill, the dog is starting to itch again. So they feel that they are hooked to the medication, and that's true. The Apoquel, when we compare with cyclosporin, for instance, has some differences. Act very quickly, is very anti-itch, but the duration of the effect is very short. Because it's a drug that has a kinetic that in 8 hours is almost gone. Then when you stop giving Apoquel, the clinical signs come quickly. Cyclosporin needs 10 days to be effective, but when it's doing the job, the efficacy lasts longer, and you can taper the doses and give cyclosporin every 2 or 3 days in many dogs. So there are some differences. The other option that we have to stop quickly the itch is Cytopoint. Cytopoint, it's a monoclonal antibody, you know well, against interleukin-31. That is one of the mediators of itch in the dog, not the only one, but one important one, and that blocks the interaction of interleukin-31 with the receptor and lasts for 4 weeks, the control of itch. The dose, it's a little bit different in different countries. In Europe, we have a dose of 1 milligram per kilo. In the US, it's 2 milligrams per kilo. There's a small difference. But the data, the most recent data, suggests that with 1 milligram, or a little bit more than 1, all the interleukin-31 is blocked. So if it doesn't work at 1 milligram, increasing the dose is not going to change the results of the treatment. What makes an increase of dose going to 2 milligrams or even more is that the duration of the effect is a little bit longer. So if you give a dog 2 milligrams per kg instead of 1, usually you go up to 5 weeks of duration. If you go very short to 1 milligram, you remain between 3 and 4 weeks. But about 30% of dogs do not respond to this treatment. And if you increase the dose 2, 3, 4 times, you are not making these dogs who become responders, because the reality is that probably there are other mechanisms causing the itch and the atopic dermatitis in these dogs, not only the interleukin-31. Apoquel and Cytopoint are similar drugs, but they are not exactly the same. So the Apoquel blocks the Janus kinase and blocks the expression of different cytokines, and therefore has a broader action. And it's also a little bit anti-inflammatory. So if you have an inflamed skin, Apoquel is more adequate than Cytopoint. Cytopoint acts only on one cytokine, interleukin-31. That is mainly a pruritic cytokine. So if you have a dog that only has pruritus and very mild lesions, Cytopoint is a very good choice. If there are very chronic inflamed lesions, Cytopoint alone is not the best option to begin with. I used to begin with oclacitinib or even oclacitinib plus some steroids. Because if we consider these 4 drugs, steroids, cyclosporin, oclacitinib, and Cytopoint, all the 4 have antipruritic effect. But not all of them have anti-inflammatory effect. Steroids are more anti-inflammatory and less antipruritic. Cyclosporin is anti-inflammatory and less antipruritic. Apoquel, it's antipruritic and also a little bit anti-inflammatory. And on the other side will be Cytopoint, that is no anti-inflammatory effect at all and only itch. So depending on the type of lesions that you have to choose one or the other drug. the data that we have, I published a paper about that, suggests that Cytopoint works in about 70% of the cases, a little bit less than Apoquel. Apoquel is over 80%. So, and both are very fast. In 1-3 days, you see the results. So the advantage of Cytopoint is that can be given to dogs of all ages. So in dogs less than 1 year, this is usually the choice. And also in dogs with other diseases. I use a lot of Cytopoint, for instance, in geriatric patients with cancer, with infections. Then when you have a dog with a history of atopic dermatitis and now is on chemotherapy with different drugs, and you don't want to add other products, the safest thing is to give Cytopoint. So in 4 weeks, using one of these drugs, you have to be able to control the acute flare. Bathing, controlling the infections, and using steroids or Apoquel or Cytopoint. And then if you have done a good job, after 3-4 weeks, the owner will come to you and say, much better, not itching so much, doing well, no skin infection, the skin looks less inflamed, it seems that everything is going well. Now is the time to talk about the long-term management, to talk to these people and say, yeah, it's doing well, but now becomes the second part of the treatment. It's keeping the dog in this condition forever. And we need to do a very, let's say, adequate step to maintain the dog under this condition. And the long-term management is more difficult. And is where, in some cases, there is a lot of frustration. And the long-term treatment, it's based on two things. Supportive treatment that all dogs need to receive, and then you have to choose what is the best way to control the disease in this specific patient. So we will change from the management of the acute flare that we decided to do with prednisolone or prednisone or clasitinib and lokivedmab, to the long term, where we are going to maintain one of these two drugs, not the prednisone, and we will consider cyclosporine or immunotherapy. Because these two are slow-acting medications that we only use for the long-term management. From the beginning, remember that we will be with frequent bathing, with adequate control of ectoparasites. Usually because we bathe a lot these dogs, we will put them on isoxazolines. We are not going to use spot-ons because we will bathe the dog every week, in some cases twice a week. And then they need to eat adequate food. Even if they are not food allergic, we know that they are predisposed to other allergies, so it's better that they eat a diet for the long-term management of the allergy condition. So what are the drugs that we can use for the long term? They can continue on Apoquel or on Cytopoint. That's a good alternative. If the owners are happy, they can continue on that and with the bathing. So we can also consider cyclosporine for the long term. Cyclosporine is different, targets a cytokine that is the interleukin-2, that is a very basic cytokine. Interleukin-2 is what we call the lymphocyte growth factor. It's essential for any immune response. And if you block interleukin-2 and some other cytokines, you reduce the itching, the allergy, and also inflammation. So it's very potent drug. It's used usually at 5 milligrams per kg. This is a low dose. The immunosuppression with cyclosporine usually begins around 8 to 10 milligrams per kilo. And if you want to get a very strong immunosuppression, you go above 15. In kidney transplantation, for instance, in humans, cyclosporine is given at 20 milligrams per kilogram. So we're using a very low dose that is enough for our atopic dogs. And it works about 75% of the cases. The problem is that it usually takes 10 to 14 days to be effective. So if the dog is on oclacitinib, you don't need to discontinue oclacitinib and begin cyclosporine, because in the middle you will have another flare of the disease. Simply begin cyclosporine and maintain the oclacitinib for 2 or 3 weeks, and then you can stop oclacitinib. And the same with the steroids. You have to begin the treatment with cyclosporine together with some steroids the first 2-3 weeks to avoid having a flare of the disease of the condition. The problem of cyclosporine is that it has more side effects than Apoquel. The most common one is vomiting. If you give cyclosporine, as indicated in some of the boxes, with empty stomach to increase absorption, between 15 to 20% of the dogs vomit at least once. They have many vomits. So it's better to give always cyclosporine with food on the stomach, with a protected stomach. And also freezing the capsules helps to avoid vomiting. If they keep the box of the capsules in the freezer, the dogs do not vomit. And you give the capsule very cold to the dog, they do not, almost never vomit. Also, another thing that you can do is, if you have an episode of vomits, wait a couple of days and restart the treatment again. That's also very effective. And if you vomit, probably the best treatment to stop vomiting is maropitan. Metoclopramide or omeprazole are even contraindicated in vomits induced by cyclosporine. So we can keep that. So cyclosporine has advantages and disadvantages. It's a drug that I use in many cases of atopic dermatitis. It's very effective, similar to steroids or close to oclacitinib. Can be used on the long term, so it's a drug that is better for the long-term management, because you can taper the dose. After 1 month giving cyclosporine every day, if the dog is doing well, I start to give cyclosporine every 2 days, every 48 hours, and then every third day. So many dogs on the long term, if they are bathed, they eat good food, they are controlled for parasites, they remain free of signs of atopic dermatitis, just taking cyclosporine 2 days a week, Tuesday and Saturdays, for instance. That's it. So it's a very good alternative. And also, you can use cyclosporine as the baseline. That's a very common combination. The dog is living on cyclosporine, tiny doses, and we know that every spring has a flare, and then we add a shot of cytopoint, for instance. This is also a good combination. The cyclosporine, it's a drug to be used as a baseline. It's not to control a flare in 2 days. The problem with cyclosporine are side effects. Vomiting, that can be up to 25% of the dogs, is easy to control with freezing the capsules, giving with food. The diarrhea that happens in about 3-4% of the dogs is much more difficult to control. When dogs present diarrhea, usually you need to stop cyclosporine. The same with the gingival hyperplasia that you have probably seen. About 3% of dogs on cyclosporine, they develop this gingival overgrowth, very typical, and then usually you need to discontinue the cyclosporine. And in some countries, price can be a limitation because cyclosporine can be more expensive than other treatments. But now we have many cyclosporines, brands of cyclosporine, so usually the price is going down and down and down. It's no more a big limitation. The other long-term option is allergen-specific immunotherapy. And we have the different laboratories offering this. I know that in Lithuania you have several, including Nextmune and others that are very, let's say, high-quality labs. And you can use the sublingual route or the subcutaneous route. At the beginning, you know that there are different protocols, but basically at the beginning you give these small quantities frequently, and then usually you end with one administration every 2 to 4 weeks. We do not understand very well this therapy from the mechanistic point of view. There are some papers showing that what happened in these dogs is there is an increase in the number of T regulatory cells and interleukin-10, and there is a good control of the abnormal immune response. And after a few months, the dog reduced the clinical signs of atopic dermatitis. The success rates that different labs say publish is about between 60 and 70% of the cases, depending how you measure the result, what do you consider success, because it's not easy. Obviously, for this therapy, you need to do a test first, not for the other therapies, not for the diagnosis of atopic dermatitis. But if you have decided that you will begin with immunotherapy, then you need to begin with a test. And you have two options, the intradermal skin test and the serum IgE detection. They both are almost the same in efficacy. So I would say if you are working mainly with skin cases and you are a dermatologist and you test dogs every day or 2 or 3 days a week, you can use the skin test because it's a test that you need to prepare the solutions. It's a little bit complicated. You need to sedate the dog, so it takes more time, and it's a good test. But for most practitioners, I think the serum-based test, it's a very good option. If it's done at a good lab, it's simply a good test. And there are papers, for instance, this one by Ralph Mueller and Sonia Betenay, published a few years ago, that showed that the response using the intradermal skin test or the IgE-based test was more or less similar. So you don't need to be obliged to do the skin test or to think, if I use the serum test, the results are not good enough. No, they tested dogs with the intradermal skin test or serological and evaluated how many of the dogs did well or excellent or good or moderate with which one, and the percentage was more or less the same. So the test doesn't make a big difference. The truth, however, is that not all dogs do well on allergen-specific immunotherapy. We have to admit that. This is, for instance, a large case, number of cases published by the University of California. They do a very good testing of the dogs. They begin very good immunotherapy. And if you see, only 20% of dogs did excellent on immunotherapy, meaning that only with immunotherapy, disease was controlled. Only, I would say, adding bathing, parasite control, basic things. No, meaning that you don't need to add steroids or cyclosporin or any other drug. About 30-something% did very well, but not enough to be only on immunotherapy. So if you join these two together, you are about 50% of dogs that have good or excellent results. And then there is some that they do moderate, 20%. They are better than before we started immunotherapy. But sometimes I need to add something. And there is about 30% that they do not respond at all. You don't see a difference. So what I tell to my clients is, it's a very good idea to try immunotherapy. But you have to know that we can have a moderate or just nothing. We can try. I will be with you. But I do not push people to do that. No, we have to try, because if then you have a fail, they say, the dog was doing so well on Apoquel and you insisted in doing immunotherapy and you feel bad because of that. And you are not guilty. This therapy works in a big percentage of dogs, but not on all dogs. And in many cases, works only partially. But it's very good because you can reduce other drugs. The first step is that you need to talk to the owners and make them clear that they will wait for 1 year, because before 1 year is not, let's say, it's not useful to evaluate the efficacy of the test. Wait at least 1 year. Then make a good selection of the allergens with clear relevance. In some cases, the test is simply negative or very weak positive. In this case, I do not begin immunotherapy and say, sorry, the test is not clear enough to begin immunotherapy. We need to have very clear results. And they will ask you, and then to what is allergic in my dog? I don't know. If your dog, in a normal test, serum test or the intradermal test that I do, I test for about 40 allergens. I explain to the owners, if your dog is allergic to one of these common things, dermatophagoides, Pteronicius, farine, other food, Tyrophagus, all the classic mites or some of the pollens that are in my area, we will see that. If your dog is allergic to a very strange substance or very strange pollen that your neighbors bought a new tree and it's all the time exposed to this is not in my panel. I will not detect that. I cannot test for everything. So they have to understand that if it's a common thing, we will detect that. If the reaction is very strong, we will detect and we can begin immunotherapy. Do not use many allergens. In human medicine, they know that you don't need to mix 10 allergens. Even if you have many positive in the test, tend to select those that are more prominent, stronger, and you don't need to use, for instance, molds in the preparation. Usually, I put the mites and a few pollens if they are clearly positive. And if you can do immunotherapy with 3-4 allergens, fantastic. And also use supportive therapy. So don't stop everything and say, now it's time for immunotherapy. I stop Apoquel, I stop bathing, I stop everything, because then you will have a flare. So you have to continue with the Apoquel, start the immunotherapy, and after 2-3 months, or the cyclosporin, say, let's try to reduce even more the cyclosporin to see what happens. The immunotherapy is a good option too. In fact, it's the only one that can cure the disease with very few side effects. You almost never see a side effect. Some dogs, after their injection, they have each 1 day. And also it can be, like the cyclosporin, used as a baseline for control on the long term. And if the immunotherapy is controlling 60% of the condition, and 2 times a year you need to give some Apoquel or some cyclosporin or some cytopoint, perfect. You don't need to give every month a shot of cytopoint. But there are some negative parts or weaknesses. You need to do a test first. There is a long time till you start to see results. You don't see in 1 month an improvement of the clinical signs. Also, there are many protocols and can be confusing. In this case, your lab can help you. If you work here with Nexmune or with LaboClean or whatever, they usually will help you. And also, it's true that they need compliance and dedication of the owners. Therefore, the selection of the pet owners is very important. You need to select people that they want to do that they ask you, is there an alternative to giving pills all the time? We want to do this. They are interested. They follow. These are the Remember that in addition to your treatment choice, you will keep the permanent flea control, parasite control. You will control secondary infections. Every time that you see this patient, you will do cytology, check the gingiva for hyperplasia. You will check the ears with cytology. So we will control these patients a lot. And they will continue with frequent bathing. And in some cases, you can also help the epidermal barrier with spot-on medications. For instance, those with sphingosine or with other lipids, they are several on the market that contain essential fatty acid that help to repair the skin. Don't use these that are very expensive medications at the beginning when there's an acute flare, because we know that the acute inflammation is the main cause of abnormalities in the epidermal barrier. So if you have a dog that is itchy, inflamed skin, it's nonsense to start to add essential fatty acids spot on or by mouth, because the inflammation that we have there, it's in some way destroying the epidermal barrier, decreasing the amount of filaggrin, increasing the permeability of the barrier. We need to normalize the skin with powerful drugs, oclacitinib, steroids, cytopine, normalize the epidermal barrier. When it's normal, it's worth to use this, because you help to, when the skin is well, to reduce the use of the other drugs. And also you can use the adequate foods for these patients, and especially those that have big amounts of essential fatty acid that reduce the inflammation. It's true that some owners will ask you, should I use complements or the essential fatty acids in food? If possible, it's much better that this addition of essential fatty acids, especially omega-3 that is anti-inflammatory, it's in the food. There are studies showing that it's better to use a top premium food with a lot of essential fatty acids, like this one, for instance, Atopic care, that is specific for the management of atopic dogs, than eating bad food and adding big amounts of essential fatty acids. So the absorption, it's much less. So what I tell them is, if possible, use one top quality food for allergic dogs. If you cannot afford that, or you have free food of the low quality, then we need to add as a supplement essential fatty acids. There are several studies showing that this approach, managing the epidermal barrier with essential fatty acids and with spot-ons, is effective. This is a recent publication in 2020. They follow a group of atopic beagles when they cause a flare of the condition with exposure to dermatophagoides. And then you see that those with the spot-on, they did much better on the long term. So it's clearly that you can manage that. This is another one using a moisturizer on the skin surface with glycerol and propylene glycol that protect the epidermal barrier. So these are all treatments for the long-term phase to reduce the use of cyclosporine, Apoquel, and so on. So, in summary, how are we going to manage these atopic patients? In two phases. Phase one is to control of the acute flare, and we will target different parts of the disease. So we will use antimicrobials, antibiotics to control infections if we have infections. We will control inflammation of pruritus using prednisone, oclacitinib, or lokibetamab. And if we want, we can begin, as soon as this is under control, the other treatments. And in the maintenance phase, we will continue with medicated shampoo. We will reduce the frequency. Long-term can be one bath every week or even every 2 weeks. We will continue with the allergen immunotherapy if we have started with that, with adequate food, with sphingolipids or essential fatty acids to repair the epidermal barrier, and one of these three drugs, if we have chosen one of them, oclacitinib, lokibetamab, or cyclosporine, on the long term. The better that we use these drugs, the less of these that we are going to use. So if the dog is very well controlled, it's parasite control, it's bathed frequently, it's eating a very good food, it's using some spot-ons to protect the epidermal barrier, probably you will need less supplements with Apoquel or lokibetamab or whatever, okay? And I think this is the last one. This is the old patient before and after. So if you target the acute flare and then try to find the best option for the long term. These dogs, they have a very good quality of life in almost all cases because it's a disease that cannot be cured, but can be managed. And I don't know if you have questions now. Here you have one.
Maybe it's a bit off topic, but I would like to ask your opinion about taking blood and sending, like, for example, Atopic disease, or what kind of food allergies they don't have. Is it worth it or not worth it?
No, it's not useful at all. So don't waste the time and the money. There are many studies showing that it doesn't work, and not a single one showing that it works. Just to give you one idea, when I was teaching in the US, in Boston, we did an experiment with the classroom. There were 80 students, and I told them, listen, this test doesn't work. Don't use it. But we are going to do a test. Do the test to your dogs, healthy dogs. And there were 80 students, about 60 of them had a dog. We took sample, we took saliva, we did the two tests, and we checked the results. Of the 60 dogs that we tested, 55 were positive to many things. And none of them had clinical signs of nothing. And even in many of the cases, they were positive to things that they have never eaten. They say, how is possible? It's positive to avocado, I never have given a shrimp to my dog. And they said, so there are so many cross reactions, it's not clinically relevant, don't do these tests. Not even, because there are some papers that say, well, it can be a pre-screening to know what to do in the diet, not even for that. So at this moment, it would be fantastic to have a serum test that helps, but it doesn't work. More comments or questions?
Is it true that if alcohol doesn't work for dog, it is not worth it to use cytokine?
No. That's a very good question too. There are dogs. We do not know exactly the reason for that, but there are clear data showing that some dogs respond to Apoquel and they do not respond to cytopine, and dogs respond to cytopine and not to Apoquel. So they are different drugs. Even the Apoquel has a mechanism that is related to the interleukin-31. So it blocks the Janus kinase, and cytopine also blocks the interleukin-31. But Apoquel also works directly on the nerve cell, blocking the signal. So they are different drugs. And then if you have a bad result with Apoquel, you can try perfectly cytopine, and the reverse. If you don't have a good result with cytopine, you can try Apoquel. It's a very good question. This is something that has been going around, and now we have more data and studies, and it's clear that you can have, in general, most dogs respond to both of them. There are 60% of dogs that respond to two drugs, but you can have cases of one or the other. More questions over there.
Aš norėčiau užduoti klausimą. Paveiksliukuose 30 ir 31 trupučiuką skiriasi dislokacija. Vienoje vietoje yra snukis, kas būdinga atopiniam dermatitui, o kitam yra akis, kas būdinga demodeksui. Kaip jūs atskiriat, jeigu tyrimas nedavė rezultatą, paėmiau skutinos ir nėra? Kaip atskirta, kad čia yra demodeksas? Kad tikrai ne demodeksas?
Well, clinically, there are many differences between the two conditions. In general, in demodicosis, at the beginning, the lesions are multifocal spots of alopecia with a non-symmetric distribution. In atopic dermatitis, you tend to have a more diffuse, not focal area, and they tend to be very symmetric. The type of lesions is also different. In demodicosis, they begin with alopecia, then move to erythema and scaling, and finally you have cross because of the furunculosis. In atopic dermatitis, you begin only with erythema and moves to lichenification. That is different. And also the distribution on the body is different. It's true that both can target the face, as you say in the images, but in demodicosis, you have more lesions on the trunk, dorsal parts, and in atopic dermatitis tend to be more ventral. In dermatitis, you tend to have lesions on the paws, and in atopic dermatitis, you do not have that. And also, in dermatitis, the areas without hair are usually spare, so nose, and mucocutaneous junction, and in atopic dermatitis, they can be affected or inflamed. So clinically, you can distinguish the two. These two dogs, for instance, they have very symmetric lesions, erythematose on the face. In dermatitis, you have more spotty. At the end, it's very easy. You can do a skin scraping. But clinically, they are really different. Dermatitis is not a very itchy condition. In the scale of itching, the average level of itchiness in dermatitis is 3. If there is a secondary infection, can be 5. In atopic dermatitis, the average itchiness is between 7 and 8. So they are much more itchy, the dogs with atopic dermatitis, than the dogs with dermatitis. So the main differential diagnosis of atopic dermatitis is food allergy and scabies. In scabies, you can have very similar clinical signs in some cases. Okay.
Norėjau dar paklausti tada dėl šuns. Jeigu apakvėlis priprato, o citapoinas nepadeda, ką tada daryti?
So the question is, if Apoquel doesn't work and cyclosporin doesn't work. Okay. So in this case, the best option that you have is to use cytopoint. And you can combine cytopoint with immunotherapy in the long term. If this is not effective either, and then the cytopoint is not working, then we need to move to a different group of drugs that they have not so much evidence, but they are called for desperate cases. And these are basically gabapentin and mofetyl mycophenolate. So these will be the two rescue drugs that we use in cases that everything previously has failed, including cytopoint. But if you have a dog that failed on aclacitinib and on cyclosporin, the next thing to try will be cytopoint and to begin immunotherapy. You can also use tiny amounts of steroids together with the cytopoint. So this will be what I will do, what I do in these cases, before moving to mofetyl mycophenolate or gabapentin.
Dėl dietos norėjau paklausti. Anksčiau, kada pakeitė dietą veterinarinę, 20 dieną buvo stabilus pagerėjimas. A dabar, kada nusimato pagerėjimas, 26 savaitę įvyksta pablogėjimas. Ir išeina, kad viskas grįžta į tą pačią vietą. Ir keičiant pašarą į kitos firmos, į hiperallergeninį nepadeda. Ką tada daryti? Nes tokių atvejų yra daug ir pašarai beveik visi, kas yra Lietuvoje populiarūs ir užsieniai, beveik visi turi tokį pripratimą.
Yeah, this is a good question, and that happens sometimes. In general, what we try to present in lectures or in books is the ideal situation. You have a dog that is itchy, you change the diet, and the dog remains itchy, not a food allergy, or improves a lot, is doing much better, and when you go back to the previous diet, the dog is itchy again. And then you know that it's food allergy. This is true and happens in many cases. But there are also the situations that you suggest. There are some dogs that improve a little bit in the middle of the food trial and then becomes bad again. Or dogs that the owners say, nah, it's a little bit better, but it's not perfect. We don't know all the details about these dogs, but we assume that these are dogs that are allergic to environmental allergens and also to some food ingredients. So the food is part of the problem. And then what I do in these cases is I consider this dog atopic dogs. I manage with the classic treatment for atopic dog, or clathidinib, cytopoint, cyclosporin, immunotherapy, whatever. And I consider to use a diet that in principle can be less harmful than eating everything. But I know that I'm not going to control these dogs with diet.
Paskutinį klausimą. Aš norėčiau paklausti testus labai domina. Kaip, kur juos gaut, kaip nupirkt ir kur tą metodiką galima paskaityti. Apie testą darymą ant nugaros alergenų. Kokios firmos jos platina?
I'm so sorry, but I cannot help you with this because I don't know what are the distributors of these tests in Lithuania. I imagine that you refer to intradermal skin test, not to the serum test, no? To intradermal?
Taip.
You, I'm sure that you will have some companies that distribute that here in Lithuania. Big companies like Greer or Arthu are distributing the tests in Europe. So maybe you can get this from other countries, or any colleagues here that can help you with this.
It is Nextmune.
Nextmune produce also tests for the intradermal skin, and you can have this in Ukraine. Nextmune is a very good company, and they do the serum-based test
And serum, they do.
and the intradermal, so you have both. It's the big one in Europe, Nextmune now.
Have you ever used it to find an animal together?
Yes, very frequently. They work very well together. It's a very good combination. So in cases, and there are two ways of doing that. So in some cases, I use Apoquel as a baseline, and there are dogs that have occasionally a flare, and then I give the cytopon. In other cases, the owners prefer the reverse situation. They prefer that I give a shot of cytopoint every month to keep the dog well. That is called the proactive cytopoint therapy that has been published. But they keep at home a few tablets of Apoquel for the bad days, between one injection and the other, and then those days they reinforce with the Apoquel. So it's a safe combination in both ways. So one as the baseline or the other one.
Do you have statistics about atopic dermatitis in dogs, maybe in cats too, maybe later? For dogs exactly, is it inhalant allergens as a reason, food allergens and environment allergens, which is contact, which is most often?
That's a very good question. What we know is the main way of penetrating the allergens is through the skin, and maybe a little bit through mucosal membranes. But we know that the beginning is the capture of the allergen by Langerhans cells of the mucosa and the skin. There is an experiment done maybe 10 or 15 years ago with atopic dogs, and exposing these dogs that were atopic to the allergen through different ways: inhalation, ears, mouth, skin. And in all cases, the clinical signs appear. So meaning that all these routes are open for an atopic dog. But the most important one was the skin. So we changed the name of inhalant dermatitis to atopic dermatitis because we think that the main route is the penetration through the epidermal barrier. But in this experiment, when they were exposed with inhalation or through the ears or into the mouth, they also had flares of the disease. So all the routes are possible.
But maybe it's when it's inhalant, now we have reactions in the mucosa mostly, probably. Or is it
Probably,
just, yeah,
but we
yes,
don't
but-
know. We
yeah.
don't know. In these dogs, they were atopic beagles. The clinical signs were more or less the same, were similar, independently of the root. So they had flares of the disease. We have used this. In dogs, it's not the best steroid. It's not the choice. In cats, we use a little bit more triamcinolone, but dexamethasone is better in cats. So we tend to use prednisolone or methylprednisolone in dogs and dexamethasone in cats. But it's true that we don't know why some dogs and some cats, when you change the steroid, do better. So in desperate cases, we try different steroids, and then even we try triamcinolone. But it's not the top steroid.
Antihistamines, how they work?
Antihistamines don't work very well in dogs or cats. So there are big discussions about that, but all the studies done with a good control show that the amount of benefit of antihistamine is tiny, so we almost never use them, unfortunately. A little bit in cats, we try when we are very, very desperate, but the studies show that there is no difference. It's almost like a placebo. Unless you give a high dose that are a little bit sedating with the, let's say, the first generation antihistamines like hydroxyzine or cetirizine or doxepin, they get a little bit of effect because they are sedating.
Aš dėl alergijų norėjau paklausti. Man atrodo, kad prie pakvėlio ir prie citaponito, nežiūrint, kad labai neseni vaistai, vyksta labai greitai pripratimas. Ir praktiškai alergijos pasidarė sunkiai valdomos. Nėra tokios teoriškai baimės, kad po pakvėlio jau niekas per daug nepadeda. Tai vat, kas po to bus, jeigu pašarai neveiksmingi, mano nuomonė, netokie veiksmingi kaip anksčiau, a pakvėlis pripratimas labai greitais, o citapontas arba neiššaukia tokio efekto, kur laukia, arba šalutinis poveikis yra didesnis ir klientas daugiau nepatenkintas, nei prieš tai tu kišiesi.
So the question is what I'm going to do if the dog is not doing well on Apoquel nor on Cytopoint. You need to try different drugs, and you have to try cyclosporin with prednisolone, or you try immunotherapy. At the end, there will be something that works. I have never had a case that I could not manage of atopic dermatitis. So at the end, you find combination of drugs that are effective. So I think it's ideal to, as you said, that with the food you can manage that, or with Apoquel. But in some cases, you need to try different combinations. With Apoquel, the lack of response is really uncommon. So when we have been following patients, it's not so common that they stop responding to Apoquel. There are dogs that do not respond from the beginning. There are dogs that need the Apoquel every 12 hours because Apoquel is a drug that has a very rapid metabolism, kidney metabolism. So when you give Apoquel, the highest blood concentration happens in 2 hours, less than 2 hours. And after 8 hours, it's almost gone from the blood. So some dogs need that you always give the Apoquel every 12 hours. That's something that happens and can be fixed in some cases given smaller doses morning and evening. There are dogs that need higher doses of Apoquel, and there are dogs that do not respond at all. But dogs that respond well and with time they are less and less responsive are really uncommon. This happens more with Cytopoint, and this has not very well understood, but it's true that after repeating injections of Cytopoint, some dogs start to have less and less improvement. We suspect that this is because the dog produces antibodies against the Apoquel. Also, Cytopoint. Also, Cytopoint is 93% a canonized antibody. There is 7% of the molecule that is not a canine sequence of amino acids. It's like it's from hamster, and they remain this part. So it's possible that some dogs produce antibodies, and then they block the cytopoint, and after a few months or years, they stop being effective. But we don't have data of how many of them they are, and the only way is to change to another medicine. And I don't know, there's a big discussion if you have a case of a dog that at the beginning responded well to cytopoint and then stopped being effective. If you wait, for instance, 1 year, if you restart the cytopoint, if this will be effective, we don't know if this is permanent or just temporary, that the loss of efficacy.
Čia smalsumas, norėčiau paklausti, jeigu taip greitai vyksta pripratimas prie pakvelio, o medžiaga nauja, a jų taip greitai nesuranda, ką darysim maždaug už 5-6 metų, kada ir šitos medžiagos save išekvos?
Yeah, the question is, what are you going to do after 5-6 years of wool control of Apoquel if the dog stops responding? You need to find an alternative. So try other drugs or try immunotherapy, that in many cases works. But yeah, it could happen. We are lucky now that we have so many drugs. When I started to do dermatology, when I did my residency, we treated all atopic dogs with steroids. There was no cyclosporin, no Apoquel, no cytopoint, nothing. So it's better.